Just a second, Karen. Yeah. Now we are live.
Okay. Hello, good evening, and thank you for joining us for the launch of Apavac into the UK. Apavac is a new product to the VetLig portfolio and made by Hastem in France and distributed by us into the UK. Some referral centres in the UK have used this product already, but the product, due to its makeup, can actually be used by any practice as long as you have a centrifuge. There are various indications for this product, with the main one being canine lymphoma. And if you're watching from an equine point of view, this is already used in the United Kingdom for melanoma in grey horses. If you wish to know which practice or which referral centre are currently using this, vaccine, please just message me or email me and I'll let you know. This year, VetLig, sorry, that's my clock. This year, VetLig will be exhibiting this product at SFONC, which is in a couple of weeks' time. We're going to take it to Beaver for equine in September and the BVOA in October as well. I'm very grateful to be able to present the experts on this product this evening. And we have Professor Laura Marcanato from the University of Bologna. She is the author of over 90 peer-reviewed papers. And actually, Laura, I saw another one last night, so I guess it's way over 91 now. So I saw another one had been released. In 2011 to 2015, she became the president of the Italian Veterinary Oncology Society. And since 2014, she's been the chair of War Group, which is the European network for canine lymphoma. Laura's done instrumental work and studies on Apavac and canine lymphoma, and I'm so grateful that you've got time to share your experience with us and help the UK understand where this product will fit in for the oncology service, which they already use and already have. We also have Dr. Patrick Fressinet. He is an MD and a PhD with over 122 publications to his name. And you have been instrumental, along with Nicole Roquet, that Apavac is even available and was created. He's on hand to answer questions and will show some slides regarding other applications for Apavac and hopefully maybe future concepts too. There is also a presentation from Thierry Aslan. Thierry is the Vice President for the Apavac product development at Hastem. And he will discuss the mode of action, how Apavac works. And hopefully he will also be with us at the end of the presentation again, should you wish to put any questions on the Q&A or on the chat. So please do ask questions. I really want to encourage this and ask the experts about this product, should you have any questions. What I'm going to do now is I'm going to screen share and play Thierry's presentation on the mode of action of Apavac. So fingers crossed this goes according to plan.
Hi, my name is Thierry Aslan, pharmacist in charge of the development of autologous immunotherapy at Hastem. My objective today is to present to you the main elements of justification of the mechanism of action of the Apavac treatment. Hastem's initial activity now consists of having designed, synthesized, and developed the application of a biocompatible material capable of selecting, concentrating, and reinjecting the patients on tumor antigens. This concept of awakening the patients on tumor systems against their own tumor from tissue flaps had already been explored some years earlier by several teams of oncologists in human health. In particular, they emphasize the associated role of the heat shock proteins produced under condition of metabolic stress in the tumor microenvironment. Since 2007, the first historical result in human health on various advanced cancer disease have showed the therapeutic interest of this technology. In this pilot study of 20 patients, No side effects were observed, with 25% of patients showing stable disease, 15% showing a partial response, and even 20% of patients showing remission. Indeed, the first oncologists promoting the use of HER protein injection and autologous tumor antigen were not able to demonstrate and reproduce the clinical efficacy of this concept in the absence of a suitable vector. So this initial result demonstrates the effectiveness of hydroxyapatite in this role. Based on the need for suitable carrier for the selection and delivery of this complex combining anti-tumor agents with HER proteins, we developed hydroxyapatite, whose chemical composition and physical properties such as grain size, porosity, surface effect, and mechanical strength allow us to create the ideal carrier. Laura Marconato's work has demonstrated clinical effectiveness in the treatment of Kanin lymphoma. In addition, and taking into account the personalized mode of action, since it depends solely on the tumor environment, several other indications are being explored. We have also initiated a collaboration with a team specializing in HER proteins at the French National Institute of Health and Medical Research to explore the mode of action of the treatment. The purpose of this presentation is to report on the content of our work. The experimental model consists firstly of building up a vaccine bank from tumors induced by injecting a cancer cell line into mice. The collected tumors will be used to manufacture the vaccine, which can be tested on syngeneic mice developing the same cancer. Of course, it will not be possible to create and cure a cancer in the same mouse for a reason related to the speed of tumor growth compared to the speed of the immune response. In contrast, if cancer is induced at D0, using the same cell line, the efficacy of the therapeutic vaccination can be tested from the injected vaccine as soon as the tumor is detectable at days 5, 7, 9, and finally 14. The data show that the Apavac treatment injected in dose of after euthanasia of the animals on day 21, the cellular infiltration of the harvest tumors is compared. Immunohistochemistry labeling showed the presence of CD4 and CD8 immune lymphocytes in the tumor when the mice were vaccinated compared to animals treated with the hydroxyapatite control alone. Even more relevant, the marker E67 corresponding to cells undergoing apoptosis demonstrated the efficacy of the treatment when the mice were treated with Apavac. To summarize and simply explain the essential role of hydroxyapatite in vectoring anti-tumor immunity, first, tumor cells release tumor antigens from their membranes, as well as HER proteins produced in large quantities under conditions of metabolic stress specific to tumor microenvironment. HER protein will bind to tumor protein as part of their chaperone functions. Complexes consisting of tumor antigen associated with HER proteins are selected, captured, and reinjected onto hydroxyapatite granules, which have been formulated and sized as an adjuvant and immunotherapy carrier. Macrophages are the first effector cells of innate immunity by phagocytes of the hydroxyapatite greens loaded with tumor antigens. On the one hand, they provoke the production of cytokine, and on the other hand, they lead to the activation of dendritic cells, which are known to be the antigen-presenting cells. Once activated, these same dendritic cells will detect tumor antigen through specific receptor and lead to the activation of cytotoxic T lymphocytes through the major histocompatibility complex. And finally, the lymphocytes then begin to destroy the tumor cells. Thank you for your attention.
Okay, so I should have stopped my screen sharing now. So Laura, I'm going to remove myself, and
Yes.
I will hand over to you.
Okay, thank you, Karen. Thank you all for being here. I'm currently having a rainstorm here in Italy, so just to avoid problems with my connections, I will turn my camera off while I talk. So, okay. Karen, just tell me, please, if you see it full screen, if I can start.
Yeah, perfect.
Okay, thank you. So basically tonight, I would like to share my experience. It's a long experience. It's 10 years that I've been working with Apavac immunotherapy, and I just want to let you know where we are and what's in the future. So I'm sure that you are all aware that in the last 2 decades, there has been a growing and renewed interest in anti-cancer immunotherapy. Immunotherapy has become increasingly available to veterinary oncology, with lymphoma being no exception. So this is my most recent search on PubMed, and you can see that there are 117 studies on canine lymphoma immunotherapy. Increasing evidence suggests that the immune system can be manipulated in different ways to recognize and fight cancer cells. And a number of immunotherapy-based strategies are being tested in ongoing clinical studies in human as well as in veterinary oncology. And the most popular immunotherapeutic approaches include therapeutic vaccines and monoclonal antibodies, anti-tumor monoclonal antibodies. Okay, so active immunotherapy attempts to direct the protective capacity of the immune system toward eliminating malignant cells. And there are several advantages in the use of active immunotherapy, including the tumor-specific immune response and the fact that active immunotherapy, conversely to passive immunotherapy, for example, establishes a long-lasting tumor immunity, so the so-called memory, thereby limiting the likelihood of relapse. The main disadvantage is that active immunotherapy has to rely on the patient's immune system, which may be compromised by the tumor itself or by previous chemotherapy. A variety of cancer vaccine approaches have been designed in the attempt to stimulate specific anti-tumor immune responses, including inactivated whole neoplastic cells, lysates of tumor cells, individual or combinations of specific tumor antigens, nucleic acids, dendritic cells, and T cells. But here we are talking about heat shock proteins. Heat shock proteins are synthesized under stress situations, including cancer, to protect cells from damage. Under normal conditions, heat shock proteins account for approximately 10% of proteins in the cell, but they demonstrate as much as a 3-fold increase in expression levels in response to stressful cellular conditions. So heat shock proteins bring tumor-associated antigens to the antigen-presenting cells, thereby activating the CD8 and the CD4 T cells. Hydroxyapatite is used in many biotechnology processes to purify proteins from biologic solutions by chromatography. And heat shock proteins have shown a particular affinity for the hydroxyapatite surface. If heat shock proteins chaperoned peptides are adsorbed at its surface by means of chromatography, hydroxyapatite also acts as a vehicle of these molecules, which may then be released into APC, the antigen-presenting cells, to be presented to the immune system. The combination of these tumor antigens, when chaperoned by the heat shock proteins, effectively induce a specific cytotoxic T lymphocyte immune response. And another consequence of the interaction between heat shock proteins and antigen-presenting cells is the natural stimulation of inflammatory cytokine release by macrophages and dendritic cells that are known to be important in the antigen-specific adaptive immunity. So here, as said before, I would like to share my experience, and it started in end of 2011. And in 2014, we were able to publish in the Clinical Cancer Research Journal the results of our clinical trial. So here we treated dogs with diffuse large B-cell lymphoma, DLBCL, with chemotherapy, so a CHOP-based protocol. And another group of these dogs also received the vaccine, and dogs were randomized to receive either chemotherapy or chemoimmunotherapy. The vaccine consists of autologous cells and is derived from autologous cells and consists of the heat shock proteins of the patient plus hydroxyapatite. So in this trial, 12 dogs received chemoimmunotherapy and 7 dogs received chemotherapy as single treatment. Time to progression and survival time were significantly longer in dogs, in vaccinated dogs, with respect to unvaccinated dogs. So the year later, we published the results on indolent B-cell lymphomas. The study design was exactly the same, with the exception that dogs were not randomized here. So the choice was left to the owners. So here we had 25 dogs treated with chemoimmunotherapy and 20 dogs treated with chemo as single treatment. And time to progression was significantly longer in vaccinated dogs, whereas there was no significant difference in survival time among groups. So we questioned ourselves and we asked why. We were hoping in a better result. And then you need to acknowledge that in 2015, the basic knowledge was not that advanced. So we were not really treating lymphoma in a different ways. So we considered the group of aggressive lymphomas and of indolent lymphomas. And probably this was the mistake, because in this particular study, all dogs with indolent lymphoma, regardless of the histotype, were treated. And we now know that indolent B-cell lymphomas behave differently based on the exact histotype. So later on, we have started to stratify indolent lymphomas according to the specific subtype. And here we have published the results of a bigger study. We treated 300 dogs. So the population was much bigger. This was a retrospective study, and the aim was to compare efficacy and safety of chemo alone, CHOP-based chemotherapy, versus chemoimmunotherapy in dogs with multicentric B-cell lymphoma of various histotypes. And a second goal was to identify the best candidates for vaccine administration. So if we considering all dogs, so the 300 dogs, regardless of the histotype, and as you can see here, it was almost half-half. So half dogs received chemo and the other half received chemoimmunotherapy. Time to progression and lymphoma-specific survival were significantly longer in vaccinated dogs compared to unvaccinated dogs. So the next step was to look deeper into subtypes. So among the 300 dogs, we had 148 dogs with diffuse large B-cell lymphoma. And as you can see here, 32% were treated with chemo only, and 68% received chemoimmunotherapy. And here we had really a great difference in time to progression and lymphoma-specific survival. Both were significantly longer in vaccinated dogs compared to unvaccinated dogs. We then looked at the nodal marginal zone lymphoma because it was the second most common histotype seen in this population of dogs. We had 49 dogs with nodal marginal zone lymphoma. The marginal zone lymphoma is an indolent lymphoma, and despite the name, so indolent, it behaves aggressively because it is more chemo-resistant compared, for example, to the diffuse large B-cell lymphoma. So here, approximately half of the population received the vaccine and the other half just received chemotherapy. And here we had time to progression and lymphoma-specific survival that tended, without reaching significance, to be longer in vaccinated dogs compared to unvaccinated dogs. So based on these studies, we documented that immunotherapy was able to provide a clinical benefit to dogs. However, because this is medicine, not all vaccinated dogs did respond well, and this was obviously disappointing for us and for the owners. So since we had a quite big population, we tried to answer this question: why does immunotherapy work or not work in individual patients? And the goal was really to find the ideal candidate for immunotherapy. So we found, based on a huge statistical analysis, that dogs with high serum LDH level at admission, those dogs having stage 5 disease, you may know that this is a negative prognostic factor. Dogs with no symptoms at admission, so substage A, and really important, dogs that had not previously received steroids were the best candidates to receive the vaccine. Oh, sorry. So we looked at the specific histotypes. So for dogs with DLBCL, if all these 4 risk factors were present, those dogs had the greatest advantage of chemoimmunotherapy. So as you can see here, the lymphoma-specific survival was 480 days versus 85 only if all 4 risk factors were present. If only 2 to 3 of these 4 risk factors were present, dogs had a significantly better outcome. However, the survival advantage was reduced with a median lymphoma-specific survival of 435 days versus 190 days only. Then we looked at the marginal zone lymphoma cases, and if 3 to 4 of these risk factors were present, then there was a significant survival advantage of chemoimmunotherapy with a median lymphoma-specific survival of 680 versus 160 days only. So nowadays, we really look at those risk factors to advise the owners to decide whether immunotherapy needs or gives an advantage if incorporated into the common standard chemotherapeutic protocol. So here I would like to show you how the vaccine is prepared, and I just want to make it really practical to show how easy it is to prepare it, because as Karen said before, you basically need a centrifuge and the right dog to be treated. So first of all, this is absolutely a rule. You need to accurately stage those dogs. So you really need to stage them to pick the right candidate. Staging includes blood work, so CBC, flow cytometry on peripheral blood. Flow cytometry will help you identifying the number of circulating neoplastic cells. And then you will run a biochemical profile, including calcium and LDH, because you have seen that LDH is a risk factor and should be evaluated to make the right decision. Then you will do FNA, obviously, and flow cytometry on the lymph node. This helps me because if I know that it's initially you may guess that it's a B-cell lymphoma, but you need to have it documented. So if you want to go ahead with the vaccine, you need to perform lymphadenectomy. This is why we usually do immediately flow cytometry on a lymph node, because we can pick the dogs with B-cell lymphoma and go ahead with lymphadenectomy. If you don't have it available or it's too expensive, then you can skip this and you will have to remove the lymph node and wait for the histology and immunohistochemistry results. Extremely important is the bone marrow evaluation by means of flow cytometry, because flow cytometry will give you the exact number of infiltrating neoplastic cells. And for the LBCL cases and marginal zone lymphoma cases, it has been associated with prognosis. So just very, very quick, here I just want to show you how easy it is to perform a bone marrow aspirate. If I can do it, everyone can do it. So you just need obviously a syringe for bone marrow aspiration, lidocaine, a scalpel, and the tubes, the EDTA tubes. You need the dog. I usually aspirate the bone marrow from the iliac crest. To me, it's very easy, much easier than the leg, for example, or the rib. So I just use a very small area on the iliac crest. This is some scrub. And then you can easily palpate the bone. This is lidocaine. So the dog, as you can see, is not sedated. I never do sedation and I never do anesthesia to aspirate the bone marrow. So I just feel the bone with the needle, and once I hit the bone, then I inject lidocaine. So here I went very fast. Usually you have to wait for a couple of minutes to have anesthesia, the local anesthesia work. and then you will make a very small incision like this. Okay, and once you're done, you go in with the bone marrow needle. We use an Illinois needle usually. You go the same way as before until you hit the bone. Okay, and once you hit the bone, you just turn your needle 180 degrees in one direction and the other. And then when you feel that your needle is fixed into the bone and doesn't move, like this, then you can go ahead and aspirate. You just need really 0.5 milliliter of bone marrow blood, and that's it. That's it. And once you have this, you can put it into your EDTA tube and send it to the lab for flow cytometry. So it all lasted 3 minutes. And it's really simple, and it gives you tons of information. So the bone marrow evaluation is a step that is, to me, really mandatory. Okay, then accurate staging also includes imaging. We usually stage lymphoma dogs with chest films, abdominal ultrasound, and FNA of the liver and spleen. Moreover, if they look sonographically normal. If you have the typical honeymoon spleen, that's infiltrated, so we don't even aspirate those. But if the spleen looks normal, then we want to obtain a cytology smear to make sure that the spleen is not infiltrated. You cannot really see by means of ultrasound the early infiltration. Okay, and once you have performed your staging workup, the next step is to remove a peripheral lymph node by means of lymphadenectomy. And it is really important to remove the whole lymph node. So not just a biopsy, you need the whole lymph node for 2 reasons. First, the pathologist will be able to give you the name and the surname of this lymphoma. Whereas if you only submit a small biopsy, the pathologist cannot really see the architecture and cannot make a diagnosis of histotype. So you really need to remove the whole lymph node. And I will show you in a minute, 1/2 of the lymph node goes to the lab, and the other half will be kept frozen for the vaccine preparation in case the dog is a candidate. And when you send a lymph node to the lab, you will have to ask for, obviously, a histologic evaluation plus immunohistochemistry. This is really important to make the right diagnosis. Okay, so here again, really fast. I'm sure you all know this, but I just want to show you exactly what we do. Okay, and once the lymph node has been taken out, then, as I said before, you need to divide it in two halves. One goes to the histopath lab, and the other one will be used for the vaccine preparation. It is important to put the lymph node for the vaccine preparation into a small container with no additives, and this needs to be frozen once you're done. So it goes with no additives into a tube, and you can keep it frozen until you have all the infos back and have your discussion with the owner. Oops, sorry. Okay, and then once you have evaluated all risk factors and you know all the relevant information on the stage, the clinical stage, the histotype, and the owner is motivated, then you can go ahead with the vaccine preparation. So here, another, I think it's the last one. No, not the last one, almost. Small video, and I wish to thank my resident, Dr. Faroni, who did that for me. So I want to show you how easy it is to prepare the vaccine.
Lymph nodes for vaccine preparation are stored frozen. In sterile conditions, extract a small piece of the tumor and cut it up into pieces. Place the extract in the sterile tube containing the ceramic balls. Use the 5 milliliters syringe to add 4 milliliters of solution A. Shake manually and vigorously for 3 minutes. Transfer all the resulting solution into the centrifuge tube using the sterile pipette provided. Avoid taking any residual tumor fragments. Centrifuge at 6,000 revolutions per minute for 5 minutes to obtain a visible pellet and a liquid phase free of solid supernatant. Keep the supernatant and transfer it into a new centrifuge tube. Use the 5 milliliters syringe to place an equal quantity of solution B as the supernatant from the previous step into a new sterile centrifuge tube. Mix the content of the two tubes together until a homogeneous solution is obtained in both tubes. After 60 minutes in the fridge, centrifuge the two identical tubes at 6,000 revolutions per minute for 30 minutes. Discard the supernatant from both tubes, retaining the pellets. Use the 5 milliliter syringe to add 1 milliliter of solution C to the pellet in each of the two tubes. Shake vigorously until the pellets are fully dissolved and transfer the contents into one single tube. Pour the content of the extraction tube into the chromatography column, cap the top with the adapter and the syringe, and shake vigorously. Allow the powder to settle, then inject air into the column so that all the liquid flows down through the powder. Add 8 milliliters of solution C into the column, then slowly depress the plunger so that all the liquid flows down through the upright column. Cap the bottom of the column. Add 4 milliliters of solution D into the column. Shake vigorously with the column upright until a homogeneous suspension is obtained. Take a 1 milliliter syringe and aspirate 0.5 milliliters of the preparation, and then proceed in the same way 7 more times, shaking strongly before each aspiration. Identify the 8 single doses with the labels provided and store them in the freezer.
And that's it. Okay, and the last step is to vaccinate the dogs. This is a dermal injection. It's not painful at all, so you don't need to sedate the dog. It's very easy. So we shave a small area like this. And we inject intradermally the vaccine, the 0.5 milliliter of the vaccine. And we really never had a side effect from the vaccine administration. And that's it. Okay, research never stops, and even though we have documented a benefit from the vaccine, there are dogs which on papers are good candidates, but they do not respond so well to the vaccine. And this is really disappointing, as I said before, not only for the owners, but also for us. So at some point, we were questioning ourselves, why does it happen? I mean, we know from all anti-tumor strategies that the response rate is never 100%, but we wanted to look deeper based on our big experience and the numerous dogs that we have vaccinated. So we pulled out from our big population 20 dogs that were matched based on, I mean, all those dogs had the LBCL, so diffuse large B-cell lymphoma, and we matched them in terms of prognostic variables, so signalment, stage, substage, steroids before admission, yes or no, and 10 dogs did really well, and 10 dogs did not. And we tried to look at these populations to find out if there was something that could help us in selecting the dogs that would benefit the most from the vaccine. And here precision medicine comes into play, So you may know that precision medicine is an innovative approach to tailoring treatment that takes into account, among others, individual variability in genes. So the one-size-fits-all strategy does no longer apply, not only to human patients, but also to canine patients. And we found out that the P53 gene was the most relevant one. P53 is the so-called guardian of the genome, and it encodes a tumor suppressor protein. So if P53 is mutated, then prognosis may be poor for many human and oncology patients. So these are the results of our study that we published on Lab Animal last year. Those dogs had all a DLBCL lymphoma. A group of dogs received chemo and another group received chemoimmunotherapy. And here you can see the differences stratified based on the presence or absence of P53 mutation. And we developed an algorithm that may be useful to you as well if you want to use it. At this website, you can download for free this kind of simulator, which may help you to really identify the dogs that can benefit the most from the vaccine. So I just want to show you real fast. Hold on one second, so you don't need this. Okay, sorry, it's in Italian, but it's very easy to understand. So here, if you open this link, you will find this kind of information. You need to put in the age of the dog, the percentage of bone marrow infiltration based on flow cytometry. So let's assume the dog is 10-year-old and that this dog has a 10% infiltration of the bone marrow. And then here you can decide, or you can try to see what happens if you treat the dog with CHOP or with chemoimmunotherapy. So if you give CHOP and P53 is sorry, it's too fast. So let's go back. If P53 is not mutated, then here you can see the probability of surviving, let's say at 1 year or 2 years. Okay, if it's not mutated, if you treat the dog with chemo. And then you can play a little bit and say, okay, what happens if I give the vaccine and P53 is not mutated? You can see that the possibility to survive at 1 year is 40%, for example. So you can play with all your numbers and you can see whether the addition of the vaccine makes a difference for the dog and also for the owners, since the owners will have to pay, and you will see the curves that come up. This is for free, and you can download it and play with your numbers. Okay, so to conclude, for every lymphoma patient, it is really important to perform an accurate staging and obtain an accurate pathologic classification. You need to know what type of lymphoma this dog is facing. And then we have documented as a whole that there is a survival benefit of the addition of active immunotherapy to chemo in dogs with B-cell lymphoma. Obviously, there are differences. So, as I said before, you should consider those 4 risk factors that are easy to evaluate. So, the substage, steroids, yes or no, and the LDH at admission and the clinical stage, obviously. And again, since we are not done with Apavac and research, and we really struggle to be really useful and find the dogs that benefit the most. So obviously the development of effective immunotherapeutic strategies, also meaning the schedule, for example, of administration or the number of doses. Today, the number is fixed to 8 doses, but maybe 16 are better. We don't know yet. So to answer all these questions, we need to take into account differences in the immune microenvironment between the different lymphoma molecular subtypes. And I'm really happy to answer questions if there are any. Okay.
Thank you, Laura. I've got one actually. The algorithm, is
Yes.
that is that in English or is it just in Italian?
It's in Italian, but it's very easy. So if you read the paper, that's obviously in English, and it's really CHOP, you understand this, CHOP and Apavac, you understand it.
Yeah.
It's ETA, which is age, and the percentage of bone marrow infiltration. These are the only infos that you need to type in. So it's, and then it's all numbers, so you can easily translate those and understand.
Okay. Shall we go on to Patrick? And then I've seen some questions that popped up. So if anybody else has got any more questions for Laura, please put them on the Q&A.
There is a question that I read, Karen. Someone is asking what is the protocol for the vaccine, and this is a really good question. So in the papers we have published the protocol, the chemo, the CHOP-based protocol is well described. So it's a very short protocol, not so dose intense, which is another advantage because you won't give basically toxicity to chemo-related toxicity to those dogs. Currently, in these days, we are trying to be more dose intense. So we are currently using a 12 weeks CHOP protocol, very simple, vincristine, cyclophosphamide, and doxorubicin, repeated for 4 weeks to see whether there is an advantage. In the paper, the results that we have published, dogs received a very short CHOP protocol with only 2 doxorubicin doses. So these results that I have shown you are based on a very short CHOP protocol, which is convenient, obviously, for costs and toxicity. Maybe there is a better protocol. We don't have the data yet, so we are collecting cases and we will see. You can email me. I don't know who you are because it's anonymous, but you can email me and I can email you back with the exact protocol that was used in those papers. I hope I answered this.
Okay, there is just one other question as well, Laura. What is your opinion on the osteosarcoma monoclonal antibody vaccine? Do you find it efficacious?
I have no experience, so I only used Apavac against lymphoma, so I have absolutely no experience on osteo, I'm sorry.
Okay, right. Laura, thank you very much. What I'll do is then I'll pass over to Patrick. That was fabulous. That's great. So thank you very much for that. And if there's any more questions at the end, we'll go through them. So Patrick, I believe you would like to screen share now.
Yes, I will screen share. Okay. Good. Maybe good. Okay. Karen, do we have to stop at 8 o'clock?
I don't think, no, I think we've got a bit of time. I don't think we're gonna, I'll ask yeah, I just ask that we don't get cut off, so don't worry, keep going.
Okay, good. So as I'm not vet by the fact, but I was there at the beginning of the story. So I would like to tell you a few words of how and why we developed this kind of vaccine. Daniel Stioka, my friend, was working in Mendoza, Argentina, on HSP, HR proteins, and he had some difficulties to purify this kind of material, these proteins. So we tried to purify this HSP with adsorption chromatography on hydroxyapatite, and we found that it worked very well. So the second question, knowing the role of HSP in CD8 cross priming, the second question was, could we associate the hydroxyapatite as adjuvant and the HSP and the chaperone protein as antigen to get a vaccine for cancer? And it's how all of this began. So when we talk about Apavac, and why is it a vaccine? It's a vaccine because there are two compounds, mineral compounds. It's hydroxyapatite. All of you know that this is the mineral phase of the bone, and the second compound is among other, but is HSP protein and the peptide and nanoprotein that they chaperone. So it's quite easy to describe the way it works. So you have a release of this HSP close to the macrophage and the dendritic cells, and the dendritic cells process this protein in order that they will present the peptides they chaperone at the surface of HLA class 1 proteins in order to see if the CD8 recognize or not these proteins. In cancer, there are many abnormal peptides and proteins, and this is how the survey of the cancer occurs normally. But when there is a cancer, every time there is an anomaly in the survey itself of the protein normal and abnormal, and that's why you have the development of the cancer, because the CD8 does not recognize the abnormal proteins. The target tissue of HA and the proteins at the surface of the HA, I mean the Apavac vaccine, is the macrophage. If you look at this section, you see on these balls are the HA particles, and you see that the cells around these surround cells around these particles are macrophages, and the particularity of this particle is that they were carrying genes, galactosidase genes that could be stained in blue on the histological section. And you see that on the histological section, almost all the cells, the macrophagic cells, were stained by this particle. And you see that there is a complete transfection of these cells by the molecules carry at the surface of the surface of the particles. So it's clear on this section that we could target the antigen presenting cells with the particle when implanted in this case it was in a bone, but in a connective tissue. And if you look, if you have a section of the surrounding bone, that you see that almost all the monocytes and the cell deriving from the monocyte, like the osteoclast, were stained in blue by the galactosidase gene. So they were all the target of the vaccine. This targeting trigger first. This is the work done by Carmen Garrido in Dijon in France. But this targeting trigger an inversion of the ratio of the M1 M2 ratio in around this particle, and you see that that M1 is are the cell, the antigen presenting cells, the macrophages, triggering the immune response, and M2 is the macrophages, inhibiting the antigen presentation and the immune reaction. So you see that when you increase this ratio, you increase the level of the percentage of M1 cells, and you increase the efficacy of the efficiency of the immune response. So this increase in the ratio trigger the infiltration of the tumor with CD4, in this case, whatever is the dosage of the vaccine, and the infiltration of CD8-2, whatever the dosage too. And you see that compared to the control, you have in the tumor, in this case it was in a mouse, but the same in dogs, in oxys, or in humans. You see that you have a big increase in apoptosis of the tumoral cells. So that's for introduce the application of this kind of technology. It's clear that Apavac is not directly a drug. It's more a cell engineering method. I mean, it's a cell engineering method using the abnormal tissue and the animal immune system in order to increase the immunity against the tumor. Hydroxyapatite is an adjuvant. It's not is not a drug either. So Laura talked about B-cell lymphoma, but we have also experience on osteosarcoma in dogs, mast cells, mastocytes, mast cell tumors, squamous cell carcinoma, melanoma, and also mammal adenocarcinoma. It's clear that it's much better if you can add surgery and even complete surgery to the vaccination. And in some cases, if you can add chemotherapy too, you have a much better result than if you use the vaccine alone. But the vaccine can be also used alone in some cases. For example, in horses, the melanoma, for the melanoma of the horses, the vaccine is always used alone. And in some cases, we have some cases of cure of the melanoma with the vaccine alone. There is a study in progress, and we will have the result of this study in progress in a few months, because up to now we have I think that we have done 50 horses, and but we have maybe Thierry Astanian is there, and he can tell how many horses are in progress today. But we will have about 120 horses, I think, in a few months. Just I gave you this this picture to show you that for the horses, once again, it's interesting because the vaccine is used alone, but you see that in these small tumors, the tumors disappeared almost totally in 3 months. But you can have also much bigger tumor in horses. For example, in this kind, it was a white horses with big tumors around the anus, and you see then within 3 months you could have a reduction, but not a disappearance, only a reduction of the size of the tumor. Okay, I think so. I have some paper or abstract which have been published in some review or in some meeting, and if some of you are interested by this paper, you can send me a mail. I will send it to you. Okay, thank you for your attention.
Super, thank you very much, Patrick. That's absolutely fabulous. That's great, thank you. And it's nice to show that we've got, I know we've got a couple of studies ongoing, and it's nice to touch on the horses, on the equines as well. We've got, right, hang on, let me just put myself back on. Okay, so we've got a couple of questions here. Thierry, thanks for joining us. I've seen you've logged on. There's a couple of questions. Any contraindication on other types of cancer than type B lymphoma? Any contraindication with any concurrent disease? So any contraindications on other types of cancer?
I can answer the second question. We have used, I mean, if there is no contraindication to chemo, there won't be any contraindication to the vaccine. So We have treated dogs with lymphoma and leishmania, for example, or tick transmitted diseases with no side effects. I really cannot recall a single side effect that was related to the vaccine. And I don't think, honestly, that if you use it with other indications for other cancers, I don't see why side effects should occur. It's really safe. That's, again, my experience is limited to lymphoma cases, but I don't see why side effects should pop up.
To my knowledge, the only contraindication we have are the T lymphomas.
Yeah, that's true.
Other what, sorry?
For T-cell lymphomas.
T-cell
We cannot
lymphoma.
use it against T-cell lymphomas. We had serious side effects initially. We did not know. So initially we were treating all types of lymphomas, and we had side effects in dogs with T-cell lymphomas. That's why it's so important to know exactly what you're treating, what you're facing. Thank you, Patrick. Yeah, that's important.
And indication of costs available. The pack comes complete, and it is £590 in the United Kingdom. That has everything in it. So one pack gives you the 8 vaccines with all the vials. So I believe the price is the same across Europe, but obviously it's sold in sterling.
Alison, I don't know if it helps, but I can share this with you. The price of the kit, as Karen said, is the same all over Europe. We charge the owners €2,000 for the vaccine.
Okay. That probably actually is helpful, because sometimes they won't. Yeah, so that is helpful to the vets to know what to charge.
I mean, it's really personal, and everyone can do whatever he wants. We charge €2,000, and in Italy, all vets who are using the Apavac vaccine charge around €2,000 for the 8 treatments.
Okay. Super. Well, I don't know if there's any more questions. Just let me have a look in the chat. I don't think we have. So I think that's it. I think we're caught up to date. I don't think so. If anybody wants to get a question in, get it in quickly now before we close. So yeah, so I think that's all. So perfect. Lovely. Well, thank you very much. Thank you, Professor Marconato. Thank you, Dr. Patrick Fressinet. Thank you, Thierry. I presented your presentation. I'm sure you'd have done it much better. But thank you all so much, and thank you for joining us.
Ciao.
Thank you. Good night.
Ciao.
Bye.
Ciao.